This brings us to the treatments. Let's look at the standard of care therapies.
The standard of care for CIDP rests primarily on three main pillars of treatment. And it is incredibly important to state right up front that currently choosing a treatment is mostly an exercise in trial and error.
Trial and error, why?
Because of that hidden engine we talked about. We severely lack reliable, easily accessible blood biomarkers that can tell a doctor exactly which immune pathway is dominating in a specific patient.
So we're just guessing.
A routine blood test cannot tell us if your CIDP is driven mostly by T cells or mostly by macrophages or mostly by complement activating antibodies. Because we don't know the exact mechanism in the individual sitting in front of us, we don't know which targeted drug will work best. So neurologists almost always start with the broad spectrum heavy hitters.
Let's start with the oldest, most common tool in the shed, corticosteroids.
Corticosteroids are the grandfathers of autoimmune treatment. They have been used to treat chronic demyelinating neuropathies since roughly 1958.
Wow, okay.
They are incredibly powerful, broad-spectrum anti-inflammatories and immunosuppressants. And they work on the immune system at two completely different levels.
How so?
First, they have profound genomic effects. When a patient takes a steroid like prednisone, the drug actually passes through the cell membrane of the immune cells, enters the nucleus, binds to specific glucocorticoid receptors on the DNA, and literally alters the gene expression of the cell.
It rewrites the software of the immune system.
Exactly. It forces the cell to upregulate the production of anti-inflammatory proteins, and it completely shuts down the genes responsible for producing those inflammatory cytokines we talked about earlier, like TNF alpha. It turns off the chemical alarms.
And the second level.
They also have rapid non-genomic effects. Most critically, high doses of corticosteroids are toxic to specific immune cells. They literally push those rogue autoreactive T cells into a state called apoptosis, programmed cell death.
It forces the soldiers of the demolition crew to commit suicide.
That is exactly what happens. It violently clears the inflammatory cells out of the nerve tissue.
But there is a massive catch with steroids. They have a reputation in the patient community for brutal, life-altering side effects.
And that reputation is entirely earned. Taking high doses of daily oral prednisone for months or years on end is systematically toxic to the human body.
Yeah.
The side effects are a nightmare: massive weight gain, severe osteoporosis leading to bone fractures, drug-induced diabetes, chronic insomnia, cataracts, and profound psychiatric changes ranging from severe anxiety to outright steroid-induced psychosis.
So how do doctors mitigate that? You have a drug that stops the paralysis but destroys the rest of the body.
This is why clinical studies like the PREDICT trial were so monumental for CIDP patients. For decades, the standard was daily oral prednisone. The PREDICT study asked a different question: what if we changed the delivery method? They compared giving patients a continuous daily oral dose of prednisolone versus giving them pulsed, ultra-high-dose dexamethasone.
What does pulsed mean in this context?
It means instead of a daily pill, the patient takes a massive, overwhelming dose of dexamethasone for just 4 consecutive days out of the month, and then takes absolutely zero steroids for the remaining 26 days.
And what did the trial actually prove? Did the pulse work?
The results changed how many doctors practice. The study showed that the pulse dexamethasone therapy was just as effective at inducing remission of the CIDP as the daily grind.
Oh, it's huge.
But crucially, because the body wasn't bathed in steroids every single day, the pulse therapy provided a much faster initial speed of action and generally resulted in fewer cumulative long-term side effects, particularly regarding things like bone density loss and weight gain. It proved we could hit the immune system hard and fast and then let the body recover, rather than poisoning it slowly.
Okay, so steroids are pillar 1. Pillar 2 is a procedure called plasma exchange or plasmapheresis. And this sounds like something out of a science fiction medical bay. It sounds incredibly intense.
It is a major invasive medical procedure. Plasma exchange is essentially a physical oil change for your entire bloodstream.
Walk us through what the patient physically experiences.
The patient is hooked up to a specialized apheresis machine. Blood is continuously drawn out of their body, usually through a large intravenous line. Inside the machine, the blood is spun in a centrifuge to separate the heavy cellular components, the red and white blood cells, from the plasma.
The plasma is the liquid part.
The yellowish liquid portion of the blood. And here is the key: that plasma contains all the circulating autoantibodies, all the inflammatory cytokines, and all the complement cascade proteins that are actively destroying the nerves.
So what does the machine do with the plasma?
It physically discards it, it throws it away. The machine then takes the patient's healthy red and white blood cells, mixes them with a sterile replacement fluid, usually highly purified human albumin, and pumps the clean mixture back into the patient's body.
You are literally washing the weapons of the immune system entirely out of the body.
Precisely. You are physically removing the pathogenic autoantibodies from circulation. And because it is a physical removal, it is incredibly, undeniably effective, especially for patients who are in an acute severe crisis.
If they're crashing.
Right. If a CIDP patient is rapidly declining, losing the ability to walk or breathe over a matter of weeks, plasmapheresis can halt the progression almost immediately. It works faster than almost any drug we have.
But just listening to that process, I imagine it is not a sustainable long-term lifestyle solution.
It is logistically and physically brutal for long-term maintenance. Think about the requirements. First, you need massive vascular access. Standard arm veins usually can't handle the high flow rates required by the machine, so patients often need a central venous catheter surgically placed in their chest or neck, which carries a constant, terrifying risk of severe systemic infection or massive blood clots.
And the time commitment must be huge.
Massive. The patient has to travel to a specialized hospital clinic multiple times a month. They sit tethered to a machine for 3 to 4 hours per session, and the procedure itself is physically draining.
Because of the fluid loss.
Taking a huge volume of fluid out of the body and replacing it causes massive fluid shifts, which can lead to severe drops in blood pressure, fainting, and painful muscle cramps from calcium depletion. Plasmapheresis is a fantastic life-saving rescue therapy, but it is incredibly difficult to sustain for years.
Which naturally brings us to pillar 3. This is the absolute cornerstone of CIDP treatment today, the most common therapy prescribed. Immunoglobulins, IVIG and SCID, intravenous and subcutaneous immunoglobulin.
Yes, for a huge portion of patients, IVI is the frontline defense. It's currently the most widely used and arguably the most versatile biological treatment we have in neurology.
Explain what it actually is. What is in the IV bag?
IVIG involves taking massive pharmacological doses of purified human antibodies, specifically the immunoglobulin G or IgG class. These antibodies are harvested and pooled from the donated blood plasma of literally tens of thousands of healthy human donors.
Wow.
This pooled liquid gold is then infused directly into the CIDP patient's veins.
Okay, I have to stop you right there, because conceptually this has always blown my mind and it sounds completely backwards.
How so?
We just spent 20 minutes explaining that CIDP is, in many cases, an autoantibody disease. The patient's own rogue antibodies are painting targets on the myelin and triggering the complement system to destroy the nerves. So the modern medical solution is to hook them up to an IV and pump their blood full of more antibodies. Millions of foreign donor antibodies. How on earth does adding massive amounts of antibodies fix a problem caused by antibodies?
It seems completely counterintuitive, doesn't it? It sounds like throwing gasoline on a fire.
Yeah.
But IVIG is a biological Swiss Army knife. It has multiple, highly complex mechanisms of action that work simultaneously to calm the immune system down.
And break those mechanisms down for us. How does the gasoline put out the fire?
First, because the IVIG is pooled from thousands of healthy people. It contains a vast array of what we call anti-idiotypic antibodies. You can think of these as antibodies designed to attack other antibodies.
Oh, interesting.
When infused, these healthy donor antibodies physically bind to and neutralize the patient's own pathogenic autoantibodies floating in the blood. They essentially hunt down the rogue missiles and disarm them before they can reach the nerves.
Okay, so it neutralizes the weapons. What else?
Second, IVIG acts as a massive sponge for the complement system. We talked about how violent the complement cascade is, punching holes in the cells.
The drills.
Well, those activated complement proteins will eagerly bind to the millions of donor IgG molecules floating in the blood. The IVIG finically scavenges the complement proteins, using them up so that they cannot assemble into that deadly membrane attack complex on the Schwann cells.
It disarms the missiles and it exhausts the explosives. But there's a third mechanism, right? One that relies on a specific receptor in the body.
Yes, and arguably, this is the most critical and fascinating mechanism of all. It relies on something called the neonatal FCA receptor, or the FcRn.
What is an FcRn receptor? What is its normal day job?
The FcRn is a specialized recycling receptor found on the endothelial cells that line all the blood vessels in your body. Normally, its job is to rescue your antibodies from being accidentally destroyed.
How does it do that?
The cells lining your blood vessels are constantly drinking in tiny gulps of blood plasma, a process called planocytosis. Whatever is in that gulp gets sent to the cellular garbage disposal called the lysosome to be broken down.
Okay.
But when a valuable IgG antibody gets swallowed up, The FcRn receptor grabs onto it inside the cell. It pulls the antibody away from the acidic garbage disposal, carries it back to the surface of the cell, and safely spits it back out into the bloodstream.
That's a life raft.
Exactly. This recycling receptor is the only reason our protective IgG antibodies last for 3 to 4 weeks in our blood instead of being destroyed in a few days. The body constantly recycles them.
Okay, so we have this recycling system constantly saving antibodies. How does dumping massive amounts of IVG interact with this?
When you infuse massive pharmacological doses of donor IVG into a patient, we're talking grams upon grams of protein, you completely overwhelm that recycling system. You saturate every single FcRn recycling receptor in the entire body. There are no life rafts left open.
And what happens to the patient's own bad antibodies?
So when the patient's own pathogenic myelin-destroying autoantibodies get gulped up by the cells, they look for a receptor to save them. But all the receptors are already occupied by the harmless donor IVG. The pathogenic antibodies are turned away, they get subbed straight into the cellular garbage disposal, the lysosome, and they are permanently destroyed. By hogging all the recycling receptors, IVG essentially forces the body to rapidly flush and destroy its own bad antibodies.
I love visualizing this. So IVG is basically like flooding a VIP club with 10,000 harmless decoy guests. The bouncers and the security systems are completely overwhelmed trying to manage all the decoys. Every seat is taken. And because of the absolute chaos, the actual rogue gang members, the pathogenic autoantibodies, get swept out the back door and thrown into the dumpster by accident because the system can't tell who to save anymore.
If we look at the overarching homeostasis of the immune system, that is a perfect analogy. You are intentionally overfizzing the body's natural balance to force it to clear out the bad actors.
It is brilliant. But IVG still requires hospital infusions, right? Massive 4-bite drips.
Traditionally, yes. A patient might spend 2 to 5 days in an infusion center every 3 to 4 weeks. However, the development of SCIG, subcutaneous immunoglobulin, has completely revolutionized patient autonomy and quality of life.
Subcutaneous meaning under the skin rather than into a vein.
Correct. With SCIG, the patient can actually self-administer the donor antibodies at home. They use a small mechanical pump to push smaller doses of the immunoglobulin into the fatty tissue under the skin of their abdomen or thighs, usually once or twice a week.
Does it work as well as the massive IV doses?
Yes, and for many patients it feels better. IVG causes massive spikes in antibody levels, followed by a slow crash over the month, which often leads to a wear-off effect, where the patient feels incredibly weak in the week before the next infusion.
Ah, I see.
Because SCIG is given in smaller, more frequent doses, it maintains a much steadier, consistent level of IgG in the blood, completely avoiding those brutal peaks and crashes.
So we have these three mighty pillars. Corticosteroids rewriting the genes, plasma exchange washing the blood, immunoglobulins overwhelming the recycling receptors. They sound incredibly powerful.
They are.
But they are still blunt instruments. They suppress huge swaths of the immune system or blindly filter the blood without knowing exactly what they are hitting. And according to the clinical data, they aren't perfect. They fail roughly 10 to 25% of patients.
Right.
What happens when the standard arsenal simply doesn't work? What happens to the refractory cases, the patients who are slipping away despite the treatments?
When standard therapies fail, we cross the threshold into the bleeding edge of modern neurology. We move away from blunt instruments and move toward precision medicine. This is where we stop carpet bombing the immune system and start looking for highly specific molecular targets. And the first major frontier in this targeted future is B-cell depletion. Specifically, a drug called rituximab.
Rituximab. We've talked about B cells. They are the factories pumping out the antibodies. How does this drug target them?
Rituximab is what we call a monoclonal antibody. It is not pooled from human donors like IVIG. It is a highly synthetic laboratory-designed weapon. It is engineered to target and bind to exactly one thing in the entire human body, a specific protein called CD20.
And where is CD20 found?
CD20 is expressed almost exclusively on the surface of mature B cells.
So it's a homing beacon specifically for the antibody factories.
Exactly. When you infuse a patient with rituximab, it seeks out and binds tightly to every CD20 positive B cell it can find. Once bound, it flags that B cell for immediate destruction by the body's own immune system. It essentially commands the immune system to wipe out its own B cell population, completely shutting down the factories that are producing the nerve-destroying autoantibodies.
That sounds like the ultimate silver bullet for an antibody disease. Wipe out the factories, end the disease. So does rituximab cure CIDP?
Here is where the story of CIDP gets highly controversial and perfectly illustrates why understanding the variance is so important. In massive, randomized, double-blind, placebo-controlled trials, which are the absolute gold standard of medical research for proving a drug or sport, rituximab largely failed.
Wait, what? If it successfully wipes out the antibody factories, how could it fail the trials?
Across the broad general CIDP population, it did not significantly delay the need for patients to get more IVG compared to a placebo. The trial was considered a negative result.
But why?
Because of that hidden engine we discussed in the very beginning. Remember, CIDP is an umbrella term. If a patient's particular version of CIDP is driven primarily by T cells and macrophages, wiping out their B cells with rituximab won't stop the demyelination. The demolition crew is still in the house. You just blew up the factory down the street.
Oh, that makes so much sense. Okay, so it failed the broad trials. Is it useless?
Absolutely not. And this is the triumph of precision medicine. While it failed the broad trials, in real-world observational data and in specific retrospective studies, neurologists saw that rituximab was producing massive, staggering, life-changing improvements, but only for a very, very specific subset of patients.
Which subset? Who is the drug actually curing?
It was curing patients who had a specific, relatively newly discovered type of CIDP driven by a very rare class of antibodies called IgG4 autoantibodies.
Let's explain IgG4. We talked about IgG as the common antibody. What makes IgG4 different?
IgG4 is a strange subclass of antibody. Unlike normal IgG, IgG4 antibodies generally do not activate the violent complement cascade. They don't blow holes in cells, instead they act like physical wedges.
Wedges.
In this specific subset of CIDP patients, these IgG4 antibodies specifically target the nodal and paranodal proteins we mentioned earlier, proteins with names like neurofacin 155 or contactin 1.
The proteins at the nodes of Ranvier, the gaps in the myelin.
Exactly. The IgG4 antibodies wedge themselves into those gaps and physically block the nerve from firing. Now, clinically, patients with these specific antinodal IgG4 antibodies often present with severe distal predominant weakness, heavy sensory ataxia, and a noticeable tremor. And crucially, they are notoriously resistant to IVIG.
Why doesn't IVIG work for them?
Because the IVG mechanisms we talked about, scavenging complement and saturating the recycling receptors, don't effectively clear out these specific IgG4 antibodies nestled deep in the nodes. IVG does almost nothing for them. They often decline rapidly. But if you give those specific patients rituximab, wiping out the B cells, producing those specific IgG4 antibodies, they often show dramatic, rapid recovery. They literally get out of their wheelchairs.
So the drug didn't fail at all. The trial design failed because we were giving a highly specific precision sniper rifle to a diverse crowd of patients instead of only giving it to the specific targets it was designed for.
Precisely. We didn't know how to identify the right patients yet. And this realization leads us directly to the next generation of precision drugs that are hitting the market right now, the FcRn blockers.
You mentioned the FcRn earlier. That is the recycling receptor inside the blood vessel cells that IVIG tries to overwhelm and saturate.
Well, instead of using thousands of dollars of precious human donor plasma to blindly flood the system and hopefully saturate those receptors, scientists had a much more elegant idea. They designed a monoclonal antibody that simply acts as a physical plug for the receptor.
Like a cork in a bottle.
Exactly. The drug is called efgartigimod, and it is the first drug of its kind approved for CIDP. It is an engineered antibody fragment. It doesn't fight infections. Its only job is to bind directly to the FcRn receptor and block it.
So it's a targeted decoy that just jams the lock.
Yes. Its affinity for the receptor is so high that it completely outcompetes the body's own natural IgG for binding. The recycling receptors are totally blocked. So the body's own IgG, including the pathogenic autoantibodies that are destroying the nerves, get gulped up by the cells, find the receptors blocked, are left stranded, and are swept straight into lysosomes and degraded.
That's amazing.
Efgartigimod forces the body to rapidly flush its own antibodies without needing a single drop of donor plasma.
Does jamming the lock actually work in clinical trials, though?
The AD-HERE trial, which is the largest clinical study ever conducted in the history of CIDP, tested efgartigimod, and the results were stunningly positive. Patients treated with efgartigimod remained relapse-free significantly longer than those on a placebo.
Do we have the numbers on that?
Specifically, 73.1% of the treated patients stayed relapse-free, compared to only 46.4% on placebo. It offered a huge, undeniable advantage, proving that aggressively lowering a patient's IgG levels is a highly effective way to stop the nerve destruction in its tracks.
Okay, hold on. This is an incredible mechanism, but logically it raises a massive red flag.
Which is?
If we use a drug like epcardigimod to plug the recycling receptors and we intentionally crash the patient's entire IgG antibody levels to clear out the bad nerve destroying ones, aren't we just completely turning off their immune system? Aren't we leaving them utterly exposed and vulnerable to every common cold, flu, and deadly bacterial infection out there?
It is the most vital safety concern when using these drugs. You are intentionally inducing a state called hypogammaglobulinemia, which means dangerously low IgG levels. However, the human body has redundancies, and the SCRN blockers are remarkably selective in how they work.
How does the body protect itself if the IgG is gone?
Because the drug only lowers IgG. It does not affect the other major classes of antibodies. It does not lower IgM, which is often the first responder to new infections. And it does not lower IgA, which protects all the mucosal surfaces in your lungs and your gut. Those antibodies continue to fight off infections normally.
Oh, I see.
Furthermore, the drug doesn't affect T cell function at all. The cellular soldiers are still on guard.
But dropping the IgG has to have some consequence.
It does. The reduction in IgG is profound, often a 60 to 70% drop in total levels. But critically, it rarely drops to absolute zero. The body retains just enough baseline immune function.
So they don't just catch everything.
In the clinical trials, while mild to moderate infections like common upper respiratory tract infections or standard urinary tract infections were slightly more common in the treated group, the rates of severe, life-threatening, opportunistic infections were remarkably low. For the vast majority of patients, the slight increase in common colds is a highly manageable risk for the massive benefit of stopping their progressive paralysis.
Okay, so we can wipe out the B cell factories with rituximab. We can block the antibody recycling with efgartigimod. What else is in the precision pipeline? We talked about the complement system earlier, the sci-fi drills punching holes in the cells. Can we stop the drills?
Yes. The next frontier is complement inhibitors. Remember, the membrane attack complex we discussed, the explosive endpoint of the cascade.
The microscopic bombs, hard to forget.
A completely new drug called riliprubart is currently making massive waves in phase 2 clinical trials. Riliprubart is a monoclonal antibody specifically designed to bind to and neutralize one single protein called C1s.
What is C1s?
C1s is the absolute tip of the spear. It is the initial spark plug that ignites the entire classical complement pathway. If you neutralize C1s, the cascade never even begins. The chain reaction is halted at step 1.
Wow.
The membrane attack complex is never formed, the drills are never assembled, and the Schwann cells don't explode.
And what did the trials show? Does stopping the drills stop the disease?
The preliminary data presented in 2024 was nothing short of remarkable. 88% of the CIDP patients in the trial who were switched to riliprubart either improved or remained stable. But the most staggering statistic was this: 52% of the patients actually improved beyond their baseline status on their previous standard of care therapies.
Meaning they got stronger than they were on IVIG or steroids.
Yes, they regained lost ground. This is a massive paradigm-shifting indicator. It proves that for a huge swath of CIDP patients, the complement cascade isn't just a secondary side effect of the inflammation, it is the primary engine actively driving the demyelination. If you turn off the complement system, you turn off their disease.
Looking at all of this, rituximab, efgartigimod, riliprubart, what does this mean for the future? We have all these incredibly specific single-target precision drugs arriving at the same time.
What it means is that we are actively witnessing a profound philosophical shift in how we understand and categorize neurological disease. These precision drugs are doing much more than just treating symptoms. They are allowing us to reverse engineer the hidden pathology of the human body.
How so?
Think about it. If a patient is completely cured by riliprubart, we now know definitively and without a doubt that their specific version of CIDP is complement driven.
Right.
If another patient fails riliprubart but responds perfectly to efgartigimod, we know their disease is driven entirely by circulating IgG autoantibodies. If they only respond to rituximab, it's a specific B cell driven process. Because we currently lack the blood tests to diagnose these pathways in advance, the treatments themselves are becoming the diagnostic biomarkers we've been missing for decades. The response to the specific drug reveals the hidden engine of the patient's disease.
That is a staggering thought. The cure actually becomes the diagnosis. You don't know what they have until you see what cures them.
Exactly.
Okay, let's take a breath and recap this massive journey we've been on today. We started by exploring the microscopic cellular mutiny of CIDP, visualizing how rogue T cells breach the blood-nerve barrier and signal macrophages to physically strip the biological insulation off the body's wiring. We navigated the confusing, shape-shifting clinical variants from the asymmetrical traps of MADSIM to the pure motor forms that can actually be worsened by the wrong medications. We broke down the rigorous, complex electrodiagnostic testing required to catch the disease, sending electrical echoes down the spinal roots to find hidden damage.
The F waves.
Right. And finally, we looked at how treatments are rapidly evolving from blunt, difficult instruments like filtering the entire blood volume or dumping in massive amounts of donor plasma to pinpoint molecular targeting that jams specific recycling receptors and halts destructive complement cascades before they start.
It is a lot of science to absorb. But the key takeaway for you, the listener, especially if you or a loved one are actively navigating the confusing, frustrating, and often frightening reality of a progressive neuropathy, is this. Understanding the sheer diversity of these variants is empowering.
It really is.
Knowing that CIDP isn't just one thing means that a non-response to one treatment, say, failing to improve on IVIG or steroids, absolutely does not mean you are at a dead end. Doesn't mean you can't be helped. It might simply mean your specific disease is driven by a different biological pathway, requiring a different molecular key to unlock it. And as we've seen, that arsenal of keys is expanding more rapidly today than at any point in medical history.
It leaves me with a final provocative thought to ponder. As these targeted drugs get more and more specific, and as they prove to us that CIDP is actually driven by entirely different microscopic mechanisms in different people, what if 10 or 20 years from now, the diagnosis of CIDP completely ceases to exist? What if the medical textbooks of the 2030s don't even contain the acronym? What if it's not one single disease at all, but just a historical umbrella term we use because we didn't know better? An umbrella for a dozen completely different immune system failures that we finally have the precise names and precise molecular cures for. We might look back at this era and realize we weren't just fighting one security system that went rogue, we were fighting a dozen